Talking about here MR evaluation of abdominal complication. So actually that here Fontan circulation is a problem. So when you have functionally single ventricle, depending on whether you have systemic obstruction or pulmonary obstruction or no obstruction, you do first stage or not. So when you have a systemic obstruction, you usually do no-root or hybrid procedure. When you have pulmonary obstruction, do the BT shunt if it is too small, and then PDA or pulmonary valve stent, or the stenosis is very balanced, you don't have to do anything. And then if you have no obstruction, you absolutely need to protect the lung by doing pulmonary artery banding. And then after that, in North America, usually between 4 to 6 months, do bidirectional cable pulmonary connection. And then the over 18 months of age, the move toward the completion of Fontan, which is usually total cable pulmonary connection. However, the total cable pulmonary connection, you rely on the systemic vein, the pulmonary arterial pressure gradient, pulmonary venous gradient, and then for fear of some systemic venous hypertension, many institutions do fenestration as an interstage. The functionally single ventricle, actually individual lesions have very low incidences. However, altogether it is approximately 10% of congenital heart disease. It's quite surprisingly, because it requires multiple surgical procedures, all congenital heart disease surgery, among them is approximately 35% of the procedures are for these cases. And then more importantly, approximately 50% of total cost for surgery for congenital heart disease is spent for Fontan or BCPC. So however, the problem is that the Fontan operation, although it is very innovative, it is only palliation, which means that relieving the cyanosis but not curing, which means that there are a lot of consequences. So the problem is the elevated central vascular, this venous pressure, which causes elevated pulmonary vascular resistance, and then there is a vicious cycle. And then usually there is a ventricular dysfunction. Altogether, there is the reduced cardiac output. And with the elevated central venous pressure and reduced cardiac output is toward the multi-organ dysfunction. The list of the complications is this many. And then actually you made the blue baby into pink, but you are stopping the functions of organs in the whole body. So today that here, I focus on the abdominal consequences of Fontan circulation. I make a joke. You can live here with the poor function of the brain, but you can't live maintain your life with bad gut and bad liver. So hepatic, the complication includes fibrosis, regenerating nodule and cirrhosis, and occasionally that carcinoma. Intestinal, the complication can be very catastrophic. The protein losing enteropathy and ascites is quite common. In the next 20 minutes or so, I want to do an overview of the hepatic and intestinal involvement of Fontan, and then we find that flow assessment of normal and abnormal abdominal circulation with MRI is very helpful in understanding of the pathogenesis of major abdominal complication. So this is normal, the circulation. You have portal venous blood flow and hepatic arterial blood flow coming into the liver. So of course that about 80% is portal venous flow and about 20% is hepatic arterial blood flow. The happening is that between these two circulation, which is the 25% of cardiac output for the 2.5% of total body weight should be through this resistant vascular channel, which is a hepatic sinusoid. So this is the case with the 16-year-old female with a double inlet left ventricle, underwent Fontan operation at the age of 2. Look at this ugly liver. So there is a beginning of liver cirrhosis. Caudate lobe is larger, and there is some fibrotic septae everywhere in the liver, except for the central region. Okay. So the literature says that histology is abnormal in 100% of the cases, and then lab test, unfortunately, is abnormal in only less than 60%, and that is called structural functional uncoupling. And if you do the MRI or CT, almost always you see abnormality of the liver. The risk factors for major adverse events late after Fontan the palliation is very interesting. The highest risk is the cases with portal hypertension. So odds ratio for that is 19 as compared to pacemaker and systemic desaturation, which are 13.4 and 0.86. So portal hypertension is a major risk factor. So this is a graph showing that years after Fontan operation, this is a survival probability. And when you have the no or one of these varix or ascites and splenomegaly, which is called the VAS score, and then your survival is reasonably okay. However, if you have a VAS score 2 or more, you have quite a rapid decline of the survival. Okay. So with that in mind, that the Philadelphia group recommends a liver biopsy and detailed cardiovascular evaluation 10 years after Fontan operation. So what about protein-losing enteropathy? Pathogenesis is not very clear, but the pathology shows intestinal lymphatic engorgement, stasis, and insufficiency. Risk factors include long bypass time, long postoperative hospital stay, high ventricular end-diastolic pressure, right ventricular morphology of main chamber, and postoperative renal failure. Diagnosis is quite tricky. You need to have the serum protein or albumin level confirmed, and then you need to look at the stool. Most accurate is a 24-hour stool clearance of alpha-1 antitrypsin. However, there is another easier test, spot test, which has less accuracy. So single ventricular survivorship, they find that PLE in Philadelphia group is in 15% of the Fontan patient follow-up. Other reports have far less the incidence, which means that depending on the diagnostic criteria, you can have more patients diagnosed as PLE, but the other institutions can have lesser number of that. So it's the accuracy of the diagnosis is not easy. So it does not have a good prognosis anyway. The age at diagnosis of PLE is median is 10 years, and years after Fontan is the 36 months, and physical findings include systemic edema in 100%, pleural effusion in 67%, ascites in 61%, steatorrhea and diarrhea in 11%. Okay. Lab findings include hypoalbuminemia in 100%, hypoproteinemia in 94%, decreased the absolute lymphocyte count in 67%, and decreased the serum IgG in 100%. Okay. So all of this, liver and the abdomen, how can you assess it? Okay. So in the imaging finding, liver usually shows the overt finding of the hepatic venous dilatation, increased water content in the damaged liver, and zonal distribution of blood flow, and increased fat content in the liver, and hypervascular regenerating nodules can be seen, and then with time, 100% patient develop liver cirrhosis, and then varices and ascites and splenomegaly very common. And then liver has the increased stiffness. So either due to venous congestion alone or development of fibrosis. And then there are increased number of cases developing liver cancer. For the intestine, mesenteric edema is from time to time seen, and then bowel wall thickening is not uncommon. In the T2-weighted imaging, where that the water content is white, how do I know? This is a spine. CSF is white, which means that white signal here is that increased water content. In T1-weighted imaging, CSF is black, and then you can see that in the same region is black. So those two, there's definitive finding of increased liver, the water content in the damaged liver. In the contrast enhanced scan, you can see multiple septi in the periphery of the liver, and in one part of the liver, more evident here, the involvement. In the advanced case, you can see certain shrinkage of the liver parenchyma with the nodularity of the liver here with the accumulation of ascites, and then you can see that there's some nodularity in the surface of the liver, in the small liver, and then large amount of ascites. So in this case, that the hepatic venous obstruction causes the infarction in the liver here, and then because of reduced blood flow to the liver, hepatic artery takes over the blood supply, and then that is the pathogenesis of development of regenerating nodule in the liver. And then this is not completely related to hepatocellular carcinoma, but however, damaged liver has a higher incidence of developing liver cancer. I don't have any experience of liver cancer in our population, but in adult literature, there are significant number of cases reported. So test of liver fibrosis, you can do ultrasound elastography or MR elastography. Honestly, I'm not very much interested in because of two reasons. One is that even if there is the increased hepatic stiffness, it is not clear whether that is due to hepatic venous congestion only, or there is a significant hepatic fibrosis. That is only significant when you do the follow-up study. You do the baseline study, when you have follow-up study, significant increase in hepatic stiffness, and then that means that there is significant interval increase in fibrosis. However, the reason I am not interested in is that this is a more remote effect of primary pathology, and we don't have much time to investigate. And then why don't you move to the more central event? So this is the imaging finding of protein-losing enteropathy. In the mesentery, you have massive edema here in this patient with ascites. And then there is the thickening of the stomach here, and then other bowels as well. So ascites, pleural effusion, mesenteric edema, and bowel wall thickening. Those are the findings of the protein-losing enteropathy. Up to now that I have shown the imaging findings of hepatic involvement and the protein-losing enteropathy. However, we are now beginning to investigate more about liver circulation and intestinal circulation with MR. Okay? So coming back to this diagram, if we have a portal venous blood flow reduced, and we all know that hepatic arterial blood flow takes over, and that is called the hepatic arterial buffer response, HLHS. So this is the adenosine-mediated hepatic arterial dilatation. However, buffering capacity is only 20 to 60% of decreased portal venous flow. Hepatic arterial buffer response is ideal, but it is impaired in Fontan patients because of limited ability to increase hepatic arterial blood flow volume due to low cardiac output status, and lower hepatic arteriovenous and veno-venous pressure gradient because of impaired hepatic venous drainage. And also, systemic desaturation, if there is, because of pulmonary arteriovenous fistula or other reasons, causes low oxygen delivery for the supplied blood flow volume. Therefore, in the Fontan patients, HABR is reduced. Okay? So how can you assess? phase contrast imaging is incredibly valuable resource. So here in this anatomic imaging, so the both kidneys are shown. This is the abdominal aorta, inferior vena cava. Here is the superior vena cava, the superior mesenteric vein, and this is superior mesenteric artery. It can be easily assessed, and then accuracy is very, very high. And then also you can look at the portal vein and hepatic artery. However, we find the hepatic artery is too small to measure directly. With this method, we measure the blood flow in the fasting stage in the superior mesenteric artery and superior mesenteric vein, and then do the meal test. Okay? So we measure the celiac axis, superior mesenteric artery and vein, and splenic artery and vein, and portal venous blood flow. And then when you have these data, you can measure the hepatic venous blood flow by subtracting the IVC flow above and below the hepatic venous conference. Renal vein flow can be measured by measuring the IVC flow above and below renal venous conference. Hepatic arterial blood flow can be estimated by subtracting the portal venous flow, the difference between hepatic and portal venous flow. Okay? So we have our fellow and our abdominal imaging, the step, the 39 healthy volunteer study. And then meal test now can be very much standardized. How? You have a very high protein content, so-called booster drink, and then we can measure the CC and then normalize to the body weight, and then give the meal before and after, they do the MRI before and after drinking this booster drink. So here is the interesting data in normal individual. This is a fasting. This is after meal. There is a little bit of increase of blood flow in the ascending aorta, which is cardiac output. Superior vena cava, there is no difference. Meal does not change your brain circulation. Common carotid artery, internal jugular vein, there is no change. Descending aorta at the diaphragm, however, there is approximately 15-20% increase in blood flow. Okay. If we look at the total abdominal blood flow between the fasting and after meal, there is a significant increase as expected. However, very interestingly, celiac axis, which gives blood flow to the liver and the stomach and spleen, there is no change at all after meal. However, superior mesenteric arterial blood flow tripled. Okay. And then superior mesenteric vein, as expected, has the same amount of superior mesenteric artery, and then that is tripled too. Because of increased superior mesenteric arterial and venous flow, portal venous blood flow has equal amount of increase. And then estimated hepatic vein flow, as expected, is the larger after meal. And then hepatic arterial blood flow, however, after meal is reduced. And there is the zero, minus zero means that almost nothing is going through the hepatic artery. Okay? So you have increased portal venous flow, and then that reduces the hepatic arterial blood flow. And renal vein flow is increased after meal. So this is what I like. Phase contrast imaging in MR, this is the one observer, the other observer. Look at the tightness of the data, and very, very accurate. So this is an example how the case I showed you already, 16-year-old female, double inlet left ventricle, Fontan at 2 years of age, clinically completely uneventful. The liver has the morphologic changes, and then superior mesenteric artery and vein a little bit reduced as compared to normal. Portal venous blood flow is reasonably okay, but however, the liver has these morphologic changes. This is a different patient, 7-year, 1 month female with a hypoplastic left heart syndrome, Fontan operation at 2 years of age. The patient has plastic bronchitis. And then, surprisingly, of course, this patient should have reduced cardiac output. However, superior mesenteric arterial blood flow is increased, but superior mesenteric venous drainage is reduced, which means that there is some loss of blood flow component between the artery and vein. And then this patient having a little bit more severe disease, portal venous blood flow is reduced. Okay? The protein-losing enteropathy case, the case I showed you, say the massive mesenteric edema, ascites, bowel wall thickening. And then here you can see superior mesenteric arterial blood flow is increased. However, superior mesenteric venous blood flow is different from arterial flow. What it means is that outgoing is not completely recovered into the vein, which means that the blood component is lost in the intestine. The fluid component will be recovered from the colon, but however, colloidal component or other non-absorbable component of blood can be completely lost. That's why that you have the albumin and total protein significantly reduced. And then with this data, the patient had the fenestration, and then after fenestration, protein and the total albumin level was recovered. So with this case, what we have in mind, we don't have enough data to talk about. Hypothesis is that this difference in superior mesenteric artery and vein could be the early sign of protein-losing enteropathy. So we have here up to now that we have about 50 cases. These are my fellow and our GI radiologist. We assessed the cases with fenestrated Fontan and completed Fontan as compared to age-matched control here. Cardiac output in normal is 3.7 liter per minute per square meter of body surface area. In completed Fontan, as expected, cardiac output is reduced. However, fenestrated Fontan patient has increased cardiac output. However, if you go to the descending aorta at the diaphragm, which is in normal 2.37, in Fontan patients there is reduced blood flow. However, in fenestrated Fontan, in the presence of increased cardiac output, there is significantly reduced blood flow to the abdomen. Why? So here the superior vena cava, which represents the cerebral circulation, is increased. And then AP collateral, aortopulmonary collateral, is large amount. What it means is that in fenestrated Fontan operation, you have increased cardiac output, but however, because of systemic desaturation, because of fenestration flow, cerebral blood flow is increased. This is normal brain sparing effect. And then there is a lot of AP collateral. Cardiac output is used mostly to support the brain and then develop the AP collaterals. Therefore, blood supply to the rest of the body is reduced. So therefore, in the fenestrated Fontan, which is a BCPC circulation, you have a significant problem in the rest of the body. So as expected, in the normal descending aorta at the bifurcation, which means that the blood flow to the low extremity is 0.85. However, in Fontan, there is a moderate reduction. In fenestrated Fontan, there is more reduction here. So here, another interesting finding is that in the completed Fontan operation, superior mesenteric arterial blood flow is maintained. There is a little bit of a reduced venous return. However, in the fenestrated Fontan operation, superior mesenteric arterial blood flow is further reduced. What it means is that the fenestrated Fontan also has the more compromised abdominal circulation than completed Fontan operation. Okay. If you look at the hepatic venous blood flow, normal is 0.98 liter, completed Fontan is 0.51. Fenestrated Fontan has more reduction than completed Fontan, and the portal vein is also the problem. If you look at the hepatic arterial blood flow, there is interesting finding. This is normal control, 0.34. However, in completed Fontan, there is some reduction. However, in fenestrated Fontan operation, there is no hepatic arterial blood flow at all, which means that fenestrated Fontan is really, really bad circulation to the non-brain, the AP collateral circulation. Okay? This is another interesting finding. This is a patient with the overt protein-losing enteropathy. This is a patient without protein-losing enteropathy. And then protein-losing enteropathy has larger difference between the superior mesenteric artery and vein, supporting the hypothesis we had. And then in those cases, there is significant loss of blood component into the intestine. Okay? To summarize what I presented up to now, we can conclude that the fenestrated Fontan is characterized by increased cardiac output with increased cerebral blood flow and AP collateral flow. Because all increased cardiac output is used by brain and AP collateral, there is significantly reduced blood flow to the rest of the body. Completed Fontan is characterized by reduced cardiac output with reduced blood flow to all body parts except the superior mesenteric artery. Certain degree of reduction of blood flow, you have your superior mesenteric arterial saving the physiology. Hepatic venous blood flow volume is reduced after Fontan. Reduction is more severe in fenestrated Fontan than in completed Fontan. Hepatic arterial buffer response is not seen in both completed and fenestrated Fontan groups. Superior mesenteric arterial flow is preserved in completed Fontan, but is reduced in fenestrated Fontan operation. And then the protein-losing enteropathy is seen in patients with the severer SMA, SMV blood flow mismatch. Finally, hepatic disease is an inevitable consequence of Fontan surgery. Various forms of hepatic abnormalities are seen in MR angiogram as soon as Fontan circulation is completed. MRI flow assessment of abdominal flow in conjunction with the multi-phase breath hold contrast angiograms may allow more accurate staging of the hepatic injuries. Thank you very much for your attention.